Welcome to another episode of 7 Minutes Medicine. Today we're going to talk about the management of Cushing syndrome. So first we're going to talk about the medication that can be used in the management of the Cushing syndrome. Then we're going to talk about our management approach. So first, there is medication targeting adrenal hormonal production. So they work on the adrenal gland level. The first medication is Ketoconazole. The most important thing about this medication, it can cause significant hepatotoxicity. So monitoring liver enzymes is very important. And if the ALT, for example, more than 3 times normal or upper limit, then you do not use this medication in the management. The other thing is you have to keep watching the liver enzymes weekly for the first month and then monthly for 3 months. If there is an increase more than 3 times the upper limit of ALT, then you have to stop the medication or you can reduce the dose. And always we have to remember this medication is teratogenic. It can prolong QT. The next medication is Methiopone. It's only short-term use and most likely used as adjunctive therapy. The third medication is ozilodrostat, and this is used if there is no surgery or surgery is not an option or if there is a failure in the surgery. Methiopone is called medical adrenalectomy. It can be used adjunctive in the ectopic Cushing syndrome, can be used in radiation patient who received radiation but it did not work as what was expected. But the most important thing to remember, this is a teratogenic medication. You monitor the response for all of those medications by following the urinary cortisol. So next, we're going to talk about the medications that target the pituitary gland. Caprigolin is the first medication and it can be used in a pregnancy. Pasireotide is a medication that can be used and can cause hyperglycemia as a side effect. And glucocorticoid receptor antagonist, mifepristone, can be used to treat hyperglycemia. About the different medications, how we treat different etiologies. So first, the management of Cushing disease, like Cushing syndrome caused by pituitary problem. We can do first option is transsphenoidal surgery of the pituitary gland. We do resection of the microadenoma and subtotal resection of the gland. We can use medical therapy as a bridging or if there's recurrence after the surgery. Mifepristone can be used to glucose intolerance, and caprigolin or pasireotide can be used to block the hormonal production of the pituitary gland. And you can use radiation, especially in kids, or if there is no successful surgery, and it will take some time for them to improve. So many times you give some medications beside radiation as a bridging. And the last thing is to do bilateral adrenalectomy. So you stop the production of cortisol hormone at the adrenal level and you give lifetime replacement. Next, we're going to talk about the management of Cushing syndrome related to the ectopic production of ACTH. And the first step is to do surgical excision of the tumor. And the question is, if the tumor is not resectable, and this is where we have other options. If you suspect that the patient does not have a long life expectancy, then you can give palliative management with Methiopone, Ketoconazole, and etomidate. But if you suspect after talking to the patient, the family, and the oncologist, the patient might have very good chance to live longer time, then you have to think about adrenalectomy. And you can do that either by the medical therapy or surgical therapy. The medical therapy, you can do it with a Methiopone or surgical management. And you have to replace the hormones after that. Mifepristone is a good option to control hyperglycemia. And as we said in our lecture in Cushing syndrome screening, hyperglycemia or uncontrolled blood sugar in patient who was before controlled is one of the signs of Cushing syndrome, and mifepristone can help with the control of the blood sugar. So the last thing we're going to talk about is the management of primary adrenal Cushing syndrome. And this is Cushing syndrome related to the adrenal gland. So if it's adenoma, then the best option is to do unilateral adrenalectomy. And just FYI, this surgery has high risk of thrombosis after the surgery, so you might need to give anticoagulation, and it's reported findings in the literature. And it has very high success rate, so it's a good option if you can do it. The second case, if you have bilateral hyperplasia, where you don't have a distinctive mass, then bilateral adrenalectomy can be done and might be preceded by Methiopone or Ketoconazole with lifelong replacement. But as we said, the decision here is to have a thorough discussion with your patient, with the care team, and with their family to have a common ground to take those decisions. Thank you so much for listening to our lecture, and please subscribe to our channel if you like our content.